So we are broadcasting now. Very exciting. The one with Peter Byers went till about 9 o'clock last night. It was great. It's really great.
That was in the middle of the night for me, so.
Yeah. He's nice. He takes such a long time, like making sure that people understand what he's explaining, and I really appreciated that.
So was it about the genetics or?
Yeah, it was genetics and VEDS, and particularly variation in families and between mutations. So what I really loved is that at the beginning of the Q&A, I asked him, you know, how would somebody know what mutation that they have? Because that's what we get asked a lot, is now there's all this buzz about the different mutations, and people are like, I didn't know there were different ones. Like, how do I know? I was diagnosed 20 years ago. So he brought up a sample test report and showed everybody what all of the little fields meant.
Yeah. Okay.
That was really valuable for people. It was sweet. So it was a lot of fun. I'm gonna miss everybody after this is over, because
I know, right?
I miss everybody all the time right now. And hopefully we have some. We're broadcasting, but we've got 0 attendees right now. So hopefully we have a few people join us. I'm sure Fran Marin will join us, and Abby DeLong. They've been at a lot of these. I think you've met both of them, Bart, over at in Nashville.
Nashville, yeah.
Yeah. Oh, we've got one. Hello, welcome. Get started in a few minutes. I don't think that's a name I've seen before. It's good to see a new name joining us. Very nice. I know that Fran Marin was posting about it in the VEDS Facebook support group today. So hopefully that grabs some people from that group to join us. And Fran is here. Hi, Fran. Good to see you. It's right now at 6 p.m. where you are.
4 minutes to go.
Is it Loeys or Loeys?
So I always say it's like the long jumper, Carl Lewis.
Loeys.
But I'm used to hearing it all different ways. So
All
that's
Lewis. Is that right?
yes.
Okay. Wow, that means I've been pronouncing Loeys Dietz wrong this whole time.
That's okay. You're not the only one.
I'm pretty sure everybody here calls it the Loeys Dietz.
Yeah, I always call it Loeys.
Yeah.
Loeys?
Yeah, that's what I say, but I'm
Loeys Dietz. I can, oh my God, I'll never be able to say Loeys Dietz.
You can do it.
I can do it.
It was funny when we published the paper on the second paper on Loeys Dietz syndrome. I got a phone call from the New England Journal of Medicine, and they were asking, "We want to do a podcast. How do we have to pronounce your name?"
Wait, so do you have a podcast on that? That's great.
Yeah, they do some kind of audio cast podcast. It's a long time ago. It's 10 years ago, so that was the beginning. I think I don't think they called it podcast at that time. They do it on scientific papers. They do some kind of audio report on that. I don't know
Very
whether it's still
cool.
available. Yeah,
That was the New England Journal of
yeah,
Medicine.
probably on the website of New England. I don't know whether they still do it or not, but at that time they did.
That's great. I'll have to look into that.
Yeah, I don't know. I never listened to it, so I don't know.
Very cool. I love podcasts. Now I'm
There's so many of them now. It's
so
like
many.
amazing.
When I first started doing my own podcast, I didn't listen to podcasts at all. There's like one fiction one I'd always listen to, and that was it. And now recently, I've really gotten into it. All sorts of different things.
Yeah. I think I learned it when I was in the States. A friend of mine was listening to Radio Lab. I don't know whether you know.
Oh yeah, I love Radio Lab.
Yeah. So that was actually the first podcast that I ever heard. It was an American one.
What is Radio Lab? I never heard of that.
From NPR radio, I think.
Oh, okay.
They choose some topics. It could be very diverse.
Mm-hmm.
They've got a lot of different ones. My mom just sent me one called Only What You Can See or something, and I still have to listen to that one, but it's about a woman who diagnosed herself with a very rare genetic condition and now has been doing this for a while. And I'm like, that one sounds very interesting to me, and I don't know which genetic condition it is, but it's on my queue for sure. So I do see that it is 12 o'clock now, so we'll go ahead and get started. Welcome everybody. I'm Katie Wright. I'm the director of the VEDS movement, if you don't already know who I am. And today I also have Susan Leshen with us. She's with the Marfan Foundation, and she'll be managing the chat box. Susan, do you want to say hello to everybody before?
Hi, welcome to the program today. It's going to be very exciting. I'm so glad to see everybody.
And we also have Dr. Bart Loeys with us, who is going to be sharing his experience with management of VEDS in children. So before we get on with the presentation, I do want to welcome you. This is the third week of the International E3 Summit, Educating, Empowering, and Enriching Our Community. This is brought to you by the Marfan Foundation and its divisions, the Loeys Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. And together we are making history. We have nearly 2,800 people registered from 72 countries across the world joining us in this International E3 Summit. So hopefully you've been able to connect with some of these people across the world through the Whova app. There's a lot of opportunities to connect with other people, which I'm sure you're already experiencing, and those have the potential to be lifelong connections. So we're very happy to be doing this. We'd like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction, for helping us bring you this International E3 Summit. And we do want to let you know that this is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Therefore, opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. So if you do have questions or need clarification about a difference in opinion between speakers that you hear, feel free to contact us at marfan.org/E3ask. That will get you to our Help and Resource Center. And just keep in mind, we're getting a high volume of questions right now, but we will get to your question as soon as we can. We're very excited to be getting such a high volume of questions and interaction with everybody. So don't hesitate to contact us. At the end of this session, if you could give us your feedback by completing the survey in the Whova app, that's where the little rate button with the 3 stars is, where the arrow is pointing. That will let us know how we're doing and how much you enjoyed this session, or hopefully enjoyed this session, and how much you were able to learn from it. So without further ado, I'm going to play the presentation that Dr. Loeys provided for us. So we'll be turning off our videos so that you can focus on the recorded presentation. We will then come back for a Q&A with myself and Dr. Loeys, and we will be answering the questions that we receive in the Q&A box. So if you have any questions during this presentation, please be sure to put them in the Q&A box. I know that if they're in the chat box, I won't see them. And if you raise your hand, it's a cool feature. It lets me know that you're engaged, but I also can't answer the raised hand there. So be sure to put your questions in the Q&A box. Thank you very much. And I'm going to go ahead and turn off my video, and we'll be back in a little while.
Good afternoon or evening to everybody. My name is Bart Loeys. I'm a clinical geneticist working in Antwerp and in Radboud University in Nijmegen in the Netherlands. And I will talk to you today about specific aspects of vascular Ehlers-Danlos syndrome in children. So, as probably most of you are aware, vascular Ehlers-Danlos syndrome, which was formerly called the type 4 EDS, is caused by a deficiency of a specific collagen called type 3 collagen. And in the clinic, the major symptoms are affecting the vasculature and the intestinal organs, and present themselves as dissections, mostly of middle-sized arteries, and intestinal or uterine ruptures. In addition, in some patients, there can be some additional skin findings and small joint hypermobility. In the past, the diagnosis was made based on decreased amount of type 3 collagen on cultured cells from skin biopsies called fibroblasts. But nowadays, the diagnosis is usually confirmed by a genetic test looking at genetic variations in the gene called COL3A1, which encodes for the information of the type 3 collagen. In 2017, a group of experts defined some specific criteria to make a diagnosis of vascular EDS. I will not go into detail of all the criteria, but on this slide you can see the major criteria, which is a family history of vascular EDS, an arterial rupture or dissection at young age, a spontaneous colon perforation, so a gastrointestinal complication, or a uterine rupture during third trimester. These are the four main major criteria, in addition to a specific finding that we will not talk about today, which is the carotid cavernous sinus fistula. But then in red, I indicated some of the minor criteria, which might be more common, the presenting symptoms in children. And these are actually the easy bruising, so children presenting with bruising that cannot be related to a trauma, and also in unusual sites where you don't expect a trauma, for example, the back or the cheeks. Children can present with thin and translucent skin, so that the skin is thin in texture, and that allows the veins to shine through. So you can see the venous pattern through the thin skin. And then other findings that we can see in children are clubbed feet. In a newborn baby, you can have a congenital hip dislocation, and very often they also present with a hypermobility of the small joints. In 2014, the group of Peter Byers in University of Washington in Seattle made a large review on how the diagnosis is usually made in children. And what they observed is that 60% of the children below age 18 that are diagnosed are indeed diagnosed because of this positive family history. And why did they decide to do the genetic testing in the children? It's first of all to eliminate the concern in children without the COL3A1 mutation that's in the family, to increase and be more prepared for complications in children with the mutation, and also to give some advice on sport and high-risk activities. Of the remaining children, about 50% of the children that are tested for vascular EDS in the absence of a family history presented with a major complication, and that was at the average age of 11 years. So that would be a vascular or a gastrointestinal complication. To start really early on, what can we see at birth? Some of the vascular EDS patients are born somewhat early, and they are born because the membranes rupture earlier than 37 weeks. Sometimes they present with low birth weight, and that's continued in the neonatal period because they also can present with feeding difficulties. And then there are some outward features that we already described, so the thin skin with easy bruising, some facial features. I'll also show some pictures in a minute. And then there can at birth already be a joint dislocation. So the most common one being at the hips, or they can have the opposite, club feet, which is the foot that are in a fixed position at birth. Sometimes there is abnormal connections between the amniotic tissue of the mom and the baby, and that can lead to deficiencies of the limbs. So here are some of the facial features that can be recognized. The most prominent for me is always the quite staring eyes that these children can present. But I should stress that definitely not all vascular EDS children do have these typical facial findings, and they can be very, very subtle or even absent in patients with proven mutations in COL3A1. So let's talk about the most common vascular complications, and I will always start from the general perspective and then zoom in on what's happening in children. I'm using some papers that have published extensive series. For example, on the vascular complications, there is a very nice French review study that followed a large cohort of patients for more than 17 years. And you can see that 51% of all the patients in this cohort do in their lifetime have a vascular complication. And if you look at the total number of complications, which is 157, you can deduce that some of these patients have multiple vascular complications throughout their life. If you look at the ages, you can see that the median age that someone presents with a vascular complication, and I will explain in a minute what these are, at a median age of 33. This is with a range which is very variable, starting at age 13, going all the way to age 70. It can be very variable, as I said. For example, not every vascular event will present itself with symptoms, and they may be self-containing. But on the other hand, they can also be life-threatening and be the cause of death in patients with vascular EDS. So what are the most common presentations? On the left, you can see a dissection, which is 70% of all the vascular complications, and that's basically a tear in the aortic wall, as is illustrated in the figure. In vascular EDS, sometimes we see aneurysm, which is a widening of the blood vessel, but this is rather uncommon in vascular EDS, which is in contrast with some other vascular diseases that we know, where aneurysms usually precede the dissection, which is not the case in vascular EDS. And then rarely you can see that it's a complete rupture. So that would mean that the complete arterial wall is decomposed and that blood comes out of the blood vessel, not just in the wall. Where do these most often happen? Most often it's the arteries that go to the organs such as the kidneys, the spleen, the liver, and the intestines. Secondly, we see it in vessels that go to the brain, called the carotid and the vertebral, so they're in the neck region. And thirdly, it's the blood vessels that go to the legs, including the iliac and the femoral arteries. What's important is that, as I said, many of these arterial vascular events are self-limiting and they might not need a specific treatment. And individualized decision is made whether you go for a surgery or a radiological intervention, which depends on the size and the location of the vascular event. And I think it's very important that we stress the need to do this in specialized centers that have specific expertise in treating vascular VDS. Secondly, is the occurrence of gastrointestinal complications. Again, the same French review study. And you can see that the GI complications tend to be somewhat earlier than the vascular. If the vascular events are in the 30s, these GI complications usually happen in the mid-20s. But again, they can happen at childhood age. The most common presentations are a perforation of the colon followed by spleen rupture. It's important to stress that like diaphragmatic hernia, which is a separation of the lung cavity and the abdominal cavity, is not part of vascular EDS, and also rectal prolapse, which is something that's happening in children, is also not often seen in vascular EDS. These data always have to be taken always have to take into a consideration that in the family, the index patient usually comes to attention because of a medical issue, which may lead to an overestimation of the incidence of a specific complication. And for example, only 20% of all the relatives did have a gastrointestinal manifestation, whereas the whole cohort, including the presenting person and the family and their family members, it's 41%. When we look on the next slide and zoom in a little bit on the pediatric age, then you can see that 8% of the people in this cohort presented an intestinal perforation before the age of 20, between 10 and 20. So before age 10, it's very almost never happening, and then it starts increasing to 8% before age 20. And you can see that throughout a lifetime, about 25%, 27 to be exact, do present an intestinal perforation. So it does happen in childhood, but fortunately it is rare. This is also confirmed in other big international studies. As you can see, both studies show about the mid-20s as the typical age, but with a range in this study going as low as age 6. And so again, when some patient is published, it's highly likely to be a bias. The most severe cases do end up in the scientific literature, whereas all the children that do not have complications are not appearing in these studies. So I think it's definitely an overestimation of the incidence or the severity. So what are important points in the GI gastrointestinal management? So first of all, it's important to maintain regular bowel movements, as constipation may be a risk factor. So you can use laxatives for that or high fiber content diet. And it's important to avoid enemas and manual disinfection, because these might increase the risk of perforation. Again, surgeries should be performed in specialized centers. And then a third complication that I added in, because it might be actually the one that's presenting the earliest, and it's shown here. It's a lung complication called pneumothorax. And as you can see, compared to the intestinal perforation and the arterial rupture, this is the one that tends to present earlier, below age 20, but fortunately it's only present in about 10% of all the patients. So it's rare, but it presents the most early from all the complications that we've discussed. So in the next section, I want to talk a little bit about what we can learn from genetics in childhood. First of all, vascular Ehlers-Danlos syndrome is what we call an autosomal dominant condition. Autosomal means it affects both males and females, and dominant means that there is a 50% chance of passing it on to the next generation if you're affected. So the reason for that is that we have 2 copies of each gene, also for collagen 3. And so one of these 2 copies carries the mutation, and whether you transmit it or not depends on whether you transmit the normal copy or the mutant copy. However, it is very important to know that in vascular EDS, 50% of the COL3A1 mutations are not inherited, and that they are the consequence of what we call a de novo mutation, which means that upon the formation of the sperm or the egg that leads to the individual, there is a new mutation that's absent in the parents, as you can see on the pedigree. So the squares are the males, the father, and the circles are the females or the mother. And you can see that there is a new mutation happening in this girl. Secondly, we've also learned that there is quite some difference in the nature of the mutations, and it might also be important to take that into account when we look at the risks for children. In general, we can make 2 big groups of mutations, which we call null mutations or haploinsufficient mutations. I'll explain that in a minute, and mutations that lead to altered quality, most typically affecting a specific amino acid in the protein. I'll explain that also in a minute. And what you can see on this graph is survival. So each time somebody dies, the curve goes down. You can see that the survival for patients that have this type of mutation called null or haploinsufficient is better than the survival of the other mutations, where you can see that the survival curve goes down steeper than in the null mutation. So why is this happening? Well, I need to explain you a little bit about the collagen formation. So a collagen fiber in our body is built up on collagen fibrils, and each collagen fibril is composed of type 3 collagen. And this type 3 collagen actually forms a helix. So it's 3 molecules that are turned around each other to form these collagen 3 molecules that then are incorporated in the collagen fibrils. And to allow this helix to form, the structure of a collagen protein is very specific. A protein is composed of amino acids. They're here the building blocks of this protein indicated by the colors. And as you can see, every third building block in this collagen molecule is indicated in green, is called glycine. And the reason that it needs to be a glycine is because glycine is the smallest building block that we have in our body, and it allows the helices to turn around each other. So the space there is less bulky, and that allows a nice collagen helix formation. So immediately you can understand when you change this important building block by a larger amino acid, that there will be a problem to form this helix. So we can learn that there is 2 major types of mutations. First, there is mutations called haploinsufficient or null mutations, and these lead to decreased quantity. On the other hand, we have what we call dominant negative, and these are the ones that affect the glycines, and they lead to decreased quality. So why is there now a difference in severity? Well, as I told you, of each gene, we have 2 copies, and you can see that here. The COL3A1 gene is represented by a green and a red dot. In both situations, there is 1 copy that's not functioning very well. In the one option of the haploinsufficient, there will be completely no protein produced from this mutant copy of the gene. So the consequence of that is that at the protein level, when we make the helix, we will make less type 3 collagen, but everything that we make is normal. So it's half of the normal amount, and we have as such a loss of 50% of the function of type 3 collagen. So that's a severe decrease, but it's less severe than when there is a problem in the mutation that leads to, for example, a substitution of this glycine molecule, of this glycine amino acid. So the gene is represented again here in green, the normal copy, in red, the copy with the mutation. But now, instead of only making half of the normal amount, as we see in the haploinsufficiency on the left, here there is 4 options. As I told you, we make a triple helix, so always 3 molecules have to come together. But if one of the 2 that we produce is abnormal, you will see that only in 1 out of 8 possibilities, you will make normal triple helix, and in 7 out of 8, or 87%, it's always abnormal, because one of the 3, at least one of the 3 protein copies is abnormal. So this explains why patients with dominant negative mutations have a more severe phenotype. And that's translated in different aspects, as you can see on this slide. It's, for example, GI complications almost never happen, especially not in young individuals that have a null mutation or haploinsufficient mutation. And for the vascular complications, they occur at least 15 years or 20 years later in patients with haploinsufficient mutation. So if you have such a mutation, the chance that you will have a complication in childhood is extremely small. A third lesson that we can learn from genetics is that in some very, very rare occasions, probably less than 1% of all the mutations in type 3 collagen, there is a mutation in both copies of the gene. And then you present with a very severe form of vascular Ehlers-Danlos syndrome, as indicated on the figure here. You don't make any normal protein. So all the protein is deficient or even completely absent. And that is leading also to additional problems, specifically in the brain development. You can observe something called polymicrogyria, which is a migration problem of the neurons in the cell, or to brain bleedings, in addition to the typical vascular Ehlers-Danlos syndrome findings, but these are more severe. So I want to end up by talking about some of the preventive measures that we can take and about the imaging strategy. So very often we get asked, what can we do with a child that has vascular Ehlers-Danlos syndrome? And I think it's very important to balance being a child and being active, and to try to avoid increased risk. So that usually means avoid contact sports because of the risk of trauma, but also not at very young age, but usually when after puberty, they start doing this type of exercise, which is called isometric exercise, which includes heavy weights, push-ups. And the reason for that is that that increases the blood pressure, and we want to avoid that. We also want to avoid activities that are causing rapid acceleration, such as the G-forces. I think it's important to carry an emergency letter or a passport indicating that the child has vascular Ehlers-Danlos syndrome and that has some contact information and some guidance on treatment. I think it's important from early on to avoid other cardiovascular factors. For example, developing hypertension should be treated very stringently. Tell the child not to start smoking, which is bad anyway. Avoid invasive procedures. Vitamin C, there is no study proving it, but it might promote collagen. So a well-balanced diet with or some additional vitamin C might be beneficial. And I think, to be honest, there is no good evidence on medical treatment with specific medications. There was a trial a couple of years ago showing effect of a very specific medication, a specific type of beta blocker, but the youngest patient included in that trial was 15 years. So we basically don't have data on what the effect of this medication in the very young children would be. I think the second main question that I get asked very often is, what about vascular imaging? Before I tell you the different strategies that you can follow, I think it's important to tell you some considerations. So first of all, a vascular event in young children, and then I would define that as below age 12, is extremely rare. Secondly, not every aneurysm, not every dissection or rupture is preceded by an aneurysm. So it means that if we do imaging studies and you have complete normal vasculature, it can give you some false reassurance, because you think, oh, there is no widening of the blood vessels, but that doesn't tell you that there is not a risk for dissection or rupture. Thirdly, I think it's important to know that not every finding on the imaging needs treatment. I told you that some of the dissections remain asymptomatic, and you will not know it unless you search for it. Not every finding is easily accessible for treatment. So it might be that we see something, but that we cannot immediately do something about it. So it also, doing imaging has some risk of creating some unnecessary anxiety. In general, we can say that there is no evidence-based guidelines. So there is not a study showing which imaging modality at which frequency would be beneficial or needed in this group of patients, especially not in children. So what I usually do, I discuss these benefits and disadvantages of knowing or not knowing with the family. And then I think there is different scenarios possible. First of all, you can decide to do no imaging at all. That's what's happening in some centers. But then I think it's very important to educate the patient, the parents, and the child about alarming signs. So if the child is experiencing very severe pain, for example, in the abdomen, that should be a trigger to go to the emergency immediately and to exclude an intestinal perforation or an arterial rupture immediately. Secondly, you can opt to do regular imaging. This could be on a yearly basis with scanners, echocardiography, MR angio or CT angio, depending on the imaging modality that's present in your centers. But again, as I told you, it might create anxiety or falsely reassure it. So it's not absolutely that this will give you guarantee that you will be able to prevent something. Thirdly, it could be a way somewhere in between, is that you do some kind of baseline imaging as soon as the child can be imaged without the need for sedation. And then you can use that as a kind of baseline comparison. And then physicians can, if something acute happens, can look back at this baseline imaging and see if that is something that's happening new or whether it was already present. So I don't think there is a good or a bad scenario. It also depends on how you cope with uncertainty and how much you feel reassured by doing these additional exams. So this was my presentation, but I would be happy to to answer your questions. Thank you.
Thank you, Dr. Loeys. That was really wonderful. And we will continue with a Q&A now. So let me stop sharing so you can see Dr. Loeys better. So we have some really great questions coming up in the Whova app during that. And if anybody does have questions, be sure to put them in the Q&A box. The most popular question right now is for a child who is diagnosed at 3 years old and is now 12 years old. They're struggling to try to live a normal life while managing VEDS. And I think you talked a bit about this safe, regular exercise. They're wondering what your suggestions are and what to do about gym class in middle school. What do you normally suggest?
Yes. So, good evening. Everybody. Oh, is there an echo? No, this is better.
That's better.
Yeah, okay. So it's indeed a very important question. And I think it's a question that we always try to answer in a shared decision-making with the parents and the child. I think I already touched a little bit on it during the presentation, but I think there's two aspects to the question. So there is, I think, the question of mostly vascular risk or GI risk. And then on the other hand, there might also be some issue with regards to the joints, which are different in consideration. So, as I said during the presentation, in order to avoid a trauma to the abdomen or to the chest, which might lead to problems with the intestines or a big vessel, we try to avoid collision sports because we think that having a trauma in a person that already has poor quality of the vessels or poor quality of the intestinal wall might increase that risk. So that's something that I would avoid. And then secondly, what we touched on is the so-called isometric exercises. So that's not really because of the trauma risk, but more because of the nature of the exercise. So in an isometric activity, you make the muscles to increase their force, but you don't create a lot of movement. And that's what we call isometric. And what's happening at that time is that the blood pressure will raise, and that's also a concern. And that's why we suggest to avoid heavy weightlifting, like push-ups, pull-ups. I think in very small children, that's usually not the type of activities that they do. But as you said, usually when they get somewhat older, some of these activity can become part of the gym, and then I would avoid them. In general, I think to have some physical activity is important, and I would really stress that we never want a child not to do anything anymore, because having physical activity is a natural way of lowering the blood pressure. We do know that if you have mild to moderate aerobic physical activity, that you lower the blood pressure, and that's good for your vessels and it's good for your health. So as a general rule, what I usually tell the people is, how do I know that I'm still doing aerobic physical activity? I have a very simple rule for that. I tell them that they still should be able to have a conversation with their friends while they're sporting, as long as they can talk and explain to their friends what they're doing, how they enjoy it, then it's okay. As soon as they cannot do that anymore, usually you're no longer in the aerobic physical activity. It's a very easy rule, and I think most people understand that and they can apply that rule. So doing light weights that don't really strain the muscles, that's fine. And so if they can still talk, then probably the weight is not too heavy. So the second aspect is the more orthopedic aspect. We do know that in some patients with vascular EDS, there can also be problems with the joints. It's not the most typical one. We see that more in other types of EDS, like the hypermobile type or the classic type, but it can also happen in vascular EDS. And there, if that's an issue, we usually recommend to avoid exercise on hard surfaces. So for example, if they do have to do running, we rather have them run on a field, a grass field, or in the woods than on a hard road, in order to protect the foot and the knees and the hips. A sport that's very popular to recommend also to reinforce the muscles and to train the muscles a little bit to compensate for the joint hyperlaxity that's there is swimming. And the reason behind swimming is that you are somewhat lighter in weight because of the lack of gravity, and that you exercise the muscles, and these can compensate for the ligaments and the capsules around the joints that are somewhat more lax. And then the last thing that I also touched on, and I think in the presentation, is the question that we get about G-forces and the fairgrounds. There usually I also tell them not to go into those with very rapid acceleration or deceleration, because we think that could also increase the risk of vessel dissection. I think something that we have to tell them is that it's fortunately still rare that we see things happen during gym classes or sports. It can happen, but I'm quite convinced that if you take those measures into account, that they should be able to participate in the gym. I think it's important to inform the teachers about it, that what they can do, what they cannot do. That can be done by a letter, which most centers will give to you, and have a conversation with the gym teacher. Usually helps also to make them understand the disease and to allow the child to participate and avoid some of the things that we don't want. And when the child gets somewhat older, I think they should also be an advocate for themselves and be able to guide people that are not familiar with the disease, what they're allowed to do or not. But I think in general, it is important that they maintain physical activity.
Thank you. And there is a presentation. That was a really great answer, and so many aspects go into this, and I know it's very complicated. We do have another session on exercise and VEDS, Marfan syndrome, Loeys syndrome on Saturday. So if anybody has not already put that on their agenda and is interested in that, that might be another one to attend to go further in depth for these questions. So the next question is regarding teaching their child who doesn't have VEDS that their other brother is more fragile. Like, do you have any recommendations for that kind of communication with a kid?
Yeah. So as a general recommendation, I usually tell the parents to answer the questions in a very open and honest way when the other child, so the sibling, is making questions. I don't think we should overload the children with information, but if they ask a question, I think we should be open and honest about it and tell them the truth. I hope that what I showed you does demonstrate that like very severe complications in children below age 12 is extremely rare, and that it's not impossible, but it's definitely not common. So I don't think the siblings should be too worried in this lower age category. When they go beyond puberty, I think it's also important to teach them about the alarming symptoms, because the parents will not always be there. They might be with friends or just with siblings. And that I think the most important things is that if the brother or the sister starts complaining about an acute pain, that should be something that's taken seriously, and that they should go and see their parents and tell them, oh, my brother or my sister told me that he has pain, and that should not be ignored. I think in that way they can help to get medical attention in a timely fashion. So that's usually how we work. In the clinics, of course, we also involve psychosocial workers that can help also the parents to educate them on how to deal with coping with the disease, but also how to share information with small children. I don't know if there is, for example, for Marfan syndrome, I know that there is a little booklet also, whether there is plans to make such things for vascular VEDS, in which they, based on a story, explain the disease a little bit, and that can be shared with siblings. So I think it would be a good idea if we can make something that's not only applicable for Marfan, but maybe also for vascular syndrome.
Yeah, and actually we're already working on that. It's in the works for a book for children for VEDS.
Yeah, it's a great tool, and it's very well appreciated by the families, with the Marfan families, that they have such a thing. So I think we need to do some effort to develop it for Loeys and vascular VEDS and all the vascular conditions that we are working with.
Absolutely. So our next question, somebody else got upvoted over our next question. It threw me off for a second. So for a child who is 6 years old and is confirmed VEDS with a splice site mutation, he had his annual MRI scan and they found white matter in his brain. Would that be concerning to you? Do you know of a connection of white matter in the brain with VEDS or any suggestions?
So they found a white matter abnormality in the brain. Is that what?
Yes.
Yeah. Okay. Yeah, of course, I cannot see the image. I'm also not a neurologist, so I would have to learn a little bit more, I think, about the details. But not every white matter lesion necessarily is an alarming sign. It could be a remnant of a small bleeding that has been there for a long time, doesn't change. So I think it's good to talk to a pediatric neurologist that is more familiar with looking at brain images to see what exactly it is. If people are thinking about this more severe form, that's usually not a single lesion. It's something that's all over the brain where you see migration pattern abnormalities and large bleeding. So I think a single white matter lesion might not be an emergency or might not be something to worry about. And it's an example of what I told in my presentation, that sometimes imaging can create more anxiety and uncertainty than it gives reassurance. So I think it's very important when you start these imagings that this has also to be discussed with the family, that not every finding that's there does need medical attention or surgery or treatment. And very often, especially in vascular EDS, we do find little changes that are there, but that are not so important to follow up on or to know. So it's always a balance between knowing and not knowing, and being reassured by a normal exam, or create anxiety by subtle findings that might not have a heavy weight to carry on.
Absolutely. And you said a pediatric neurologist would be the person to...
Yeah, I think they are probably the people that are most familiar with looking at brain imaging and see if there is in the white matters some changes, whether that's relevant or not.
Okay. And the next question is about medication. I think you went over this briefly. What is your view on medication like beta blockers for preventative treatment in young children with VEDS?
Yeah, so there is no scientific data for vascular EDS. As I said, the youngest patient that was included in the trial that looked at the effect of celiprolol, which is this very specific beta blocker, was age 15. So that means that below age 15, there was nobody in the trial. If we make it a little bit broader and look at Marfan disease, which might not be the same, which is not the same as vascular EDS, I think one of the things that we learned from the trial, but that was also the first time that it was studied, is that starting earlier was beneficial. In the Marfan trial, children were treated with a beta blocker or losartan, and they started at age 6 months, and the inclusion went all the way up to age 25. And then when you make bins by, let's say, 6 months to 5 years, 5 years to 10 years, 10 years to 15, 15 to 20, is that what we noticed is that the rate of growth of the aneurysm, which is typical in Marfan and not in VDS, so there's already a difference, that the decline in that growth was better the younger we started with the treatment. And that was both true for the beta blocker and losartan. I think in the vascular Ehlers-Danlos community, there's a lot of discussion ongoing now on which treatment is the best. The celiprolol trial is there, but there was quite some criticism also on that trial because, for example, not all the patients that were included in the trial, we know for sure that they had vascular EDS because they didn't have mutation testing. That was just because at that time that was not so common to do yet. So that makes it difficult to look at the results. It was also not a blinded trial, which means that the physician knew which medication the patient was getting, and that's some kind of trial, that's okay, but it's not the best type of trial that we can do. So I think there is a lot of discussion ongoing now to repeat that trial, maybe in combination with also comparing it to losartan. I usually also discuss with the parents the benefits and what we know and what we don't know. For example, there is also mouse data that suggests that giving this medication might be bad, that it makes the situation worse. So there's all types of evidence, and it's very hard, of course, to compare a mouse with humans. But if we explain the advantages and disadvantages, what we know or what we don't know, again, I try to make a shared decision with the parents. I do think within the community, we do have a high need of new trials that look at possible new medications that go beyond beta blockers and beyond sartan. Because my personal opinion is that neither of the two are the perfect medication for vascular EDS at this time. The other issue in the follow-up of those patients, or looking at the effects of medication, is that in contrast, for example, with Marfan syndrome, we cannot rely on the growth of the vessels because they don't always develop aneurysms. So then you have to wait long enough until the patient does have a dissection. But again, not every dissection is symptomatic and important. So how do you weigh those different events towards each other in the treatment groups? That's also a difficult issue. So I think another job that the scientific community has to do is to have a good outcome measure. Like, how do we know that this is really making a difference in the complications and the survival of the patients? And that's not so easy for vascular ehlers-Danlos syndrome. That's not because of the bad scientists, but because the disease is somewhat more mysterious in that perspective, I think, than other diseases that we know that present with aortic dissections. So that's also important, and you probably need a very long follow-up also after you started the treatment to see or to be really able to judge a comparison or a comparative treatment between beta blocker and losartan. I think it's still the issue also that ciliprol is not available in the States, right?
Right.
Yeah. So I would say that about half of my patients are on some medications, half of them are not, and it's the outcome of a shared decision. So I don't have a strong opinion in favor of either of them.
Thank you very much for sharing that. For the next question, you did talk a little bit about pneumothorax and it being something that maybe happens a little bit earlier than some of the other complications. Are you aware if that is predictive of future arterial events?
I don't remember in the study whether they looked at that or not. I have to look it up. I'm not sure. I don't think so. Also, it would probably be hard to study it because it only happens in 10% of the patients, the pneumothorax. So it is the earliest presentation, but it's also the least frequent one. So I think it would also be hard statistically to make a correlation between the two of them. And you probably also need a better, what we call a prospective study. So that means that we start now and then we start following the patients. Because if you do that type of analysis on retrospective data, it's always a little bit skewed because you see more patients that have the complications than the ones that never have a complication at all because they don't come to medical attention. So I think the question is probably still open in the air.
Okay, and I think that research was Dr. Shalhoub.
Yes, yeah. I would have to read the paper again to see if they looked at that correlation. I don't remember it from the paper.
Okay. Thank you. For someone who's had, so their son and husband have been genetically diagnosed with VEDS, and their daughter had whole exome sequencing to rule out VEDS, which was negative for VEDS. But they have other symptoms like hypotonia, feeding issues, lax ligaments, and feeding issues. How often is there a negative genetic test that's a false negative? Is that common?
Wait, I'm not sure. So there is a family history of vascular EDS?
There's a family history of vascular EDS, and the father and the son,
okay.
and the daughter had negative whole exome sequencing.
Okay, so if they know the familial mutation, then the geneticist should be able to look exactly at that position in the whole exome sequencing data. So the issue with whole exome sequencing data is sometimes that specific parts of a gene are not incorporated in the test, but then the geneticist can tell you that. He can say, I saw that part that I need to see, or I didn't see it. So if the geneticist tells you in the exome data, I was able to see the normal sequence or the spot where the other family members do have the mutation, then I would think it's 100% sure that the daughter does not have it. If the geneticists tell you, I did not see the part of that gene in your whole exome sequencing data, then you cannot make a conclusion, and then you need to do a specific test that looks at that specific region. So it's somewhat unusual that you use whole exome sequencing to look at a specific mutation, but I'm assuming that in this context, the reason for that is that that child also had some connective tissue findings, and that they maybe wanted to also have the opportunity to look at other things beyond vascular EDS. That's what I think probably happened. But again, it's a question that you can ask your geneticist, and he can give you a 100% sure answer whether what needed to be seen was seen, and then it's completely rules out the familial mutation. In general, when we do familial testing, and we do an individual in whom the diagnosis is not yet made, then when the lab does the test, they always run side by side an individual that does have the mutation of that family, so that they know that when we do the test, we did see what we needed to see in the person that was already known to be affected, and then they can compare that to the finding in the pre-symptomatic testing, so the person that doesn't know yet, and then you know also 100% sure whether you tested it or not. So that's what we call normal laboratory practice, or good quality lab quality. So they should never do a test without running what we call a positive control. So that means that you want to confirm that your test did work as you were predicted. And if you don't see the mutation in your positive control, so in the affected family member, then you know that something went wrong in your test. So again, when you do that, it also gives you 100% certainty, and you should not have a false negative result. I think for testing of for familial mutations, so mutations that are present in the family, having false negative results is nearly impossible. Of course, a lab can always make a mistake, but due to the technology, that should not be a problem. It's different when you do a diagnostic test and you don't know the mutation yet and you're searching for the mutation. I think then there's always a small chance that we missed it because it's in a location that we didn't look at, or the technique is not perfect in detecting it. But that's very different from testing a familial mutation.
Thank you. We have quite a few good questions left, and I know that we won't get to all of them, so we will get to as many as we can. We got a couple minutes left. For lifting objects for a child with VEDS, how do you know what's too heavy for a child to lift?
Yeah, so if you lift the weight and you cannot move the muscle anymore, then it's too much. That's what we call isometric. Yeah, so if it's a lightweight and you can easily move your arm and then it's okay.
Okay.
I would not put the weight on it. I would just, yeah, it should move
lifting
easily.
objects.
Yeah, same for lifting objects.
Okay.
If you really feel that the muscles are straining and you don't make any movement anymore, then it's too much.
Great. Okay, so the next question, and this will probably be our last one for today. Is there any data that I can track or measure with my own VEDS health that could benefit my 10-year-old daughter with VEDS? I feel like my health and experience should help her anticipate issues, but I feel like I should be doing more. Is there anything a parent with VEDS can do to help their child?
Yeah, I think we put some things on the website. So there's what we call a do's and don'ts sheet that's developed by Vascular, which is the European group, and I think the VEDS movement also has some fact sheets that can be used by the patients and be taken to their physicians. So I think we put it in the chat box or the Q&A box, or was it?
I think Susan Leschen will be putting that information in the chat box in Hula,
Yeah.
so you can report
Yeah.
there.
Yeah.
Okay.
And they are really good resources to get some answers to common questions, I would say.
Okay, thank you. And maybe do you have time for one more?
Sure.
One more. Okay, so would you vary preventative measures for children with haploinsufficiency variants?
Yeah, I think you can probably be more liberal in them because their complications tend to occur much later in life. So I think the risk for them is lower than in the children with glycine substitutions.
Okay, thank you so much, Dr. Loeys. And I'm going to bring up this here. So that concludes our Q&A. If you didn't get your question answered, please submit them to our Help and Resource Center at marfan.org/E3Ask. This is the same link as earlier. Just be aware that we are receiving a high quantity of questions right now during this International E3 Summit, but we will get to your question as soon as we can. If you could complete the session survey that we pointed out in the Whova app earlier, we would so much appreciate your perspective on how you enjoyed this session and what you learned from it. We have a few more days left of the International E3 Summit, so connect with community in the Whova app and visit the exhibitors in our virtual exhibit hall, and use the hashtag E3Summit20 to share your experience on social media with this summit. We're really excited to be able to bring such a large event to people internationally, and would just love to see everybody connect online and through the Whova app. If you'd like to help us make more programming possible, you can do so at marfan.org/donate. That will help us continue these really wonderful programs. And if you aren't already aware, Aortic Disease Awareness Week is just around the corner, September 19th to the 26th. We hope you join us in raising your hand awareness for vascular Ehlers-Danlos syndrome and all of the syndromes and conditions that can lead to aortic disease. So we really hope you join us during that. You can look for more information at marfan.org and I believe in the Whova app as well. So thank you so much, everybody, for joining us. Dr. Loeys, do you have any parting words for everybody before we leave today?
No, I'm always available to answer questions also, so don't hesitate to send emails. I try to answer them as much as possible.
Great. Thank you so much for your assistance to this community and for everything that you do. And thank you, everybody, for joining us today or tonight or whatever time it is, wherever you are. We really appreciate it and hope you have a great rest of your day. Thank you.
Have a good night.